Two. So good evening, everyone. On behalf of TaskMed, I would like to welcome you all to Medcast Insights into Healthcare, a learning initiative by TaskMed. Today, it's a great pleasure to have with us Dr. KVS Kumar, who is a consultant endocrinologist at Magna Endocrine Center, Hyderabad. Welcome you, sir. Sir, we look forward to hear from you on today's topic of discussion, insights into diabetic dermopathy. Over to you, Dr. Kumar.
Thank you, Team TaskMed. Thank you for the invitation. In the next 15 to 20 minutes, we shall be discussing about a specific diabetes complication. I would say specific and possibly one of the most common. I hope I am audible and my slides are visible.
Yes, sir.
Okay. So we shall go, dermatological manifestations are one of the commonest ones which patients have, but I would say they are more of a nagging to the patient rather than giving them trouble. So that is why people don't pay much attention to them. They are seen in almost about 2/3 of the population with diabetes, both type 1 and type 2. They have similar number of patients, and surprisingly, some of these are same between both the types of diabetes, unlike say nephropathy or neuropathy, where the differences are there as far as the incidence and all are concerned. Here it is almost the same. The good metabolic control definitely has a key role to play, especially in patients, which will help you in improving some of these complications. Now, when you look at the skin complications, the issue is it is like you can divide them into people who have skin lesions strongly associated with diabetes, or maybe which diabetics are more prone for infection, so they have that as a possibility, and lesions secondary to any complications of diabetes. Somebody develops a neuropathy or a vasculopathy, they develop an ulcer, so that can also lead to a complication because of a complication of diabetes. And some of the drugs which we routinely use, be it oral or injectable, can have the complications specific to the skin. So these are the common garden complications or skin manifestations which are seen in patients with diabetes, the diabetic dermopathy being the commonest, and necrobiosis diapotica diabeticorum being most specific, because this cannot be seen in anything else other than diabetes, whereas dermopathy, similar looking lesions are seen in other disorders also, but not very specific to the diabetes. Acanthosis again is a very common thing in clinical practice, vitiligo especially in type 1s. Of times, and some of these characteristic lesions are like the necrobiosis lipoidica, acanthosis, eruptive xanthomas, and lichen planus, and the bulle, and especially in somebody who has got a swollen feet, there may be a cellulitis or there may be Charcot's foot. That is important to identify. And the neovascularization of the iris, which is a diabetes rubiosis, which can also be there. So amongst, if you look at all these complications, the dermopathy is the most ignored because it doesn't trouble much other than the discoloration. So that is where possibly it's the most ignored complication of the diabetic patients. Also commonly known as shin spots. There are multiple round oval macules or shins. They're more common in men than compared with the females. And to classify them or to be justified in the diagnosis, you should have more than 4 lesions, and it is a marker, a subclinical marker of a microvascular disease, which has got high correlation with the diabetic retinopathy. So the lesions are well demarcated, hyperpigmented, macules or papules, anterior and lateral surface of the legs, and most common cutaneous marker of diabetes, and it is found in about 12.5 to 40% of patients with diabetes. And some case series have showed a very less number of these manifestations, only because possibly they have picked up the patients early in the course of the disease, and majority of them had a good glycemic control. So that is why you didn't have these manifestations in some of the studies. And what exactly is the cause of diabetic dermopathy? Unfortunately, the pinpoint cause is not known, but being shin, being anterior surface, it's more exposed to the microtrauma. So people will say it's like a mechanical or dermal trauma which could have led to this. And some patients, there may be coexisting associated neuropathy. And some patients where they have looked at the histological data said that there is a red blood cell extravasation and there is capillary basement membrane thickening, which could have contributed because of the ischemic changes locally. And another important thing, there is reduction of skin flow by virtue of these capillary basement membrane thickening. So the blood flow compromise happens, which also is a significant contributory factor for this. And another important thing, this is one of the commonest accompaniment to the classical triopathy, that is the nephropathy, neuropathy, and retinopathy. The symptoms vary from person to person. It can be reddish brown, round oval scar-like patches, usually a small size, multiple. Common garden variety, you get to see about 5 to 10 on both the legs put together. And only when you inspect the legs or for the pedal edema or for peripheral circulation, you get to see, and that is the time actually patient also notices for the first time lesions primarily on the shins, but sometimes rarely they can be seen over thighs, arms, and trunk also. And they're usually harmless and they don't cause, unlike other skin lesions and even in the diabetes, they don't cause any of the other symptoms like burning or stinging. And usually they are in a cluster of lesions, they are at a single cluster, multiple clusters, and they have it's a papule, maculopapule, so you don't actually have any elevated thing, it's only a discolorated patch. So you don't have altered local sensation, neither it breaks or like a bullet, or is it contagious. So it doesn't spread out from one place to another or one person to another, because it's not a infectious in etiology. So if you just by looking at the legs, you should be able to identify that the person has got diabetic dermopathy, and the size, shape, color, and the number of lesions will give you the clue to the diagnosis. So the diagnosis is mostly clinical, so we need not worry about doing any specific investigations for it. So it is a clinical diagnosis. So the importance lies here. Once we have diagnosed the diabetic dermopathy, how best to address the problem and improve it. Unfortunately, not many things exist, because actually the problem is lack of therapy actually leads to lack of addressing the clinical problem, because you have no product to offer to improve this condition. Most of the times practitioners, what they do is you advise them about the moisture, you advise them about any coconut oil or anything just to maintain the moisture. But the drawback with them is only they have no specific mechanism of action in the pathophysiological formation of these lesions. So they just maintain the nutrition, but you're not looking at the antimicrobial, antioxidant, or other properties which these are required, which help them in healing and which help them in preventing the further occurrence of it. The another common problem with moisturizer is you have paraben, which is actually a lot of patients have a skin irritation and inflammation with it. So patients do complain that it is like after applying so and so cream, my things got aggravated, whereas previously I was better. So it is like you should be careful enough not to prescribe anything going to be harsh on the skin and which can aggravate the irritation and inflammation. So what should be the best possible option to address the problem with diabetic dermopathy? And you should give some agent which hydrates the skin and prevents the transepidermal water loss. So that's important, that ongoing oozing and ongoing transepidermal water loss prevented. And you should have the same compound which will reduce the inflammation and which will help in the reepithelialization, so that the new tissue takes on and the old tissue is taken off, and which helps in creating the more collagen in the bed, so that the healing process is faster. So you should have a product which will help in maintaining the moisture, maintaining the surface barrier, preventing the collagen damage, and then have some additional properties of anti-inflammatory, antibacterial, antifungal, and antioxidant properties, which is possibly paraben free, and this will help the patient achieve a comprehensive therapy of the diabetic dermopathy, and which will prevent these lesions and which will prevent the cosmetically disfiguring lesions over the skin. So you have a beautiful product from TaskMate which will help in almost all these areas put together, and which will help improving these patients with the diabetic dermopathy. I've finished here. If there are any questions, I shall be happy to take.
So request the participants, if they're having any question, we can put in the Q&A box.
We have actually restricted to only a specific complication of diabetes, so that is why possibly things are a bit more narrowed down.
Yes.
If you look at, say, skin complications of diabetes, it's like a huge thing. So anything and everything. But once you have restricted to a diabetic dermopathy, that becomes a very narrowed spectrum of disease area. That must be the reason.
Exactly. So I feel, sir, we can conclude the session.
There are no. Yeah.
Okay. So thank you, Dr. Kumar, for joining us with us today. It was really an insightful discussion for us as well as for our listeners. And I would also like to thank all the doctors for being with us and for their active participation during the session. Thank you and have a great day. Thank you.
Thank you. Same to you. Take care. Stay safe.
Thank you so much, sir. Thank you.
Bye.